Hello, and welcome to the Smart Injury Doctors Podcast, the injury market's top program for doctors, lawyers, and insurers who want to gain greater insight on how to improve patient recovery results and deliver better services in the U.S. injury market. Please welcome your host, Dr. Jeffrey Allen Cronk.
All right, doctors, what I want to talk about today is deposition mastery. A lot of doctors get in, kind of uptight when they get into a deposition, and depositions are a part of the personal injury market. So you got to get used to depositions. They don't happen as much as they used to, but you still have to get very, very good at depositions. So I, constantly ask, well, what's the key to being good in a deposition? And the key is not only for me, but for the students and the doctors that I've trained. I've had doctors that have gotten as a lead testifying chiropractor and the lead expert in a spinal soft tissue injury claim, testifying on spinal instability, got a $6.2 million settlement. I've had chiropractors that have gotten $1 million in future care. I've had a number of chiropractors get $1 million settlements, plus $1 million settlements, and they're basically the lead on testifying on spinal injuries. So the key to depositions is really easy. You basically have to understand you're not there to be a patient advocate, an insurance advocate, a plaintiff attorney advocate. You're there basically to be a clinical science advocate and clinical rationale advocate. And all you got to do is tell the truth of what you did. And that's the easiest way I can say that. Now, in order to do that, you got to have standardized procedures. You can't be all over the place with your procedures, because then you have to remember what you did. So an injury patient comes into your office. The first thing you're going to do is obviously going to test for ligament damage, and you're going to know exactly how much ligament damage there is. If you're not suspecting a fracture, if you're suspecting a fracture, then you got a different scenario, right? But what I mean by a different scenario, obviously the patient would have a CT, they'd wait until there's any fracture reduction, till the fracture is completely healed before they would ever see a chiropractor. So let's just talk about the normal cases that you're talking about, which are soft tissue injury cases. You got to know the ligament damage. Where is it? How bad is it? You got to know if there's disc. Is there disc complication with it? If so, where is it? How bad is it? And then all you have to do in a deposition is basically explain what you did and not put yourself in a position where you feel like you have to defend. So the biggest challenge that I have when I'm training attorneys or training doctors, we do it on a Smart Injury Doctors program. So any month where there's 5 weeks, on the 5th week, we do a deposition coaching training. And the biggest thing that doctors learn is how to stay on offense and not be on defense. And what I mean by stay on offense is you're going to put forth things that cannot be argued. For example, guidelines. Guidelines can't be argued. Treatment guidelines can't be argued. AMA impairment guidelines can't be argued. Surgical guidelines can't be argued. Athletic return to play parameter guidelines can't be argued. They're right there. They're written for everybody to see. What Medscape says about an injury can't be argued. So what you want to do is you want to put yourself and your documentation standardly in place where it's communicating for you, and it's not communicating anything that could really be attacked. It's just communicating the truth. And the truth is, yes, you're in a clinical science, and yes, that's not an exact science, but there are guidelines that basically state exactly how bad an injury is. So, for example, let's just take the impairment guidelines. People love the impairment guidelines. So let's just take the impairment guidelines. Alteration, motion, segment integrity. Good, people have heard of that. And they use it, and I think a lot of times they use it in ways that are problematic for them, and no one understands the way they explain it. But let's just take the impairment guides, 5th edition, AMA. If I have a 25% whole person impairment due to 3.7 millimeters of translation at C4 and C5. Okay, what is that equal to fracture-wise in that same guideline? What's equal to a greater than 50% compression fracture? Okay, so that may be if somebody's trying to minimize it. The guidelines say it's comparable to that level of fracture. So you can't minimize that. The guidelines are stating it. The guidelines are way more knowledgeable than you and I are. There's way more consistency there. And so it's what people have already agreed on this injury means. If I look at, say, an Aetna surgical guideline, and it says 3 millimeters of back and forth translation qualifies the patient for spinal fusion surgery, I'm not saying that. These guidelines are saying that. They're saying that this injury was that bad. So what you want to do is you want to put yourself in a position to be on offense where you don't have to defend yourself. And so, like a person, I'll show you a defense. And this will be one of the things, the biggest things I have to train our doctors on is that before you answer a question, understand the question. If you don't understand the question, counter question. So the attorney says, Dr. Cronk, what about the patient's pre-existing conditions? Now, you might actually go, well, you're worried about the fact that, there was a accident 3 years ago and there was an MRI that showed a disc bulge at that point. And basically you have now a disc herniation at the same level in this accident and you're worried. So the person says, what about pre-existing conditions? And you automatically assume he's talking about the disc. You have no idea from that question. Doctor, what about the pre-existing conditions? Counter question. What pre-existing condition? Which one are you referring to? And then if I don't understand the one that they're referring to, I counter question until I do understand, and then I don't answer the question until I do understand the question. See, a lot of you are worried about what the person's going to ask you, so you practice, you already have all these things in mind of what you're going to say. And as soon as they punch the button, you start talking. Okay, that's not the way to do a deposition. The way to do a deposition is to stay on offense, is to understand what it is that they're asking you, and then putting forth information that makes it very easy for anybody to argue, or makes it very difficult for anybody to argue, right? So that's the key. I mean, you're sitting there, you got the injury, you got the permanency, you got what the person can't do as a result of the injuries, what the person can do but has difficult time doing. You basically have established the future care needs. You're basically all guideline compliant. You've discussed the results. You've discussed the outcome assessment. You have outcome assessment procedures that show if you made any referrals, you have good notes on exactly what those are. Any pre-existing conditions, you have good notes and documentation on what those are, and a good explanation for why or what. So let's talk about a pre-existing condition. A woman's pregnant. Right? She's 7 months pregnant. She's in an auto accident. She has relaxin running through her body. That's a pre-existing condition. It's going to soften the ligaments so that basically the ligament structure can open in her pelvis, so she has a easier time with the birthing process. Now, if she breastfeeds, the relaxin is not going to leave her body, so she breastfeeds for 6 months. Guess what? She's going to have that hormone interfering with care potentially. Nobody can argue that. But if you don't bring it up and you don't understand it, then it makes depositions a lot more difficult. Dr. Cronk, why did this patient, take so long in care? Well, isn't it true she didn't make all of her appointments? If you're like all of a sudden talking about things that really are not all that relevant. Yeah, she didn't make all of her appointments because she's a new mom. But the biggest problem with her is that she has a hormone running through her body called relaxin. It's a pre-existing condition. It's prior to the accident. Or let's say it was during the accident. It doesn't matter. Okay, you have to understand what is the patient's, what does your patient have? Let's say the patient came off, let's say they came off chemotherapy. They just came off chemotherapy and now they got into an accident, right? Intensive chemotherapy. What's intensive chemotherapy going to do? It's going to resist their body's ability to repair itself. Look up chemotherapy and what it does to the body's ability to repair itself. It's going to be problematic. But if you're not documenting that early on and now the patient is long in care and everybody's questioning why, well, you haven't documented the pre-existing condition that would explain the reason why. And so depositions are going to be a lot harder for you. You're going to have to rely on other things. So when you're working the patient up from day one, you're working up the ease of your deposition. Like I don't have to, if I'm working the patient up, I'm going to, in the initial consult, I'm going to start working up pre-existing conditions, and I know exactly what they are. And so I know what I might be asked. I'm going to work up what the injuries are because I've got a standard process for doing this. Standard for my x-ray, standard for measuring excessive motion, standard for disc herniation and referrals out if I need to. Standard for what my treatment is. Standard of what my reevaluation schedule is. Standard of what I'm doing on re-exams and how I'm basically dosing or rescheduling, resetting up the treatment plan. That's optimal treatment plan. I do this a lot, so I know exactly what I'm doing with it. And I do it the same all the time. I'm not saying each patient is all the treatments the same. That's unique. But the procedures I'm doing are not. I can just look it up. What does my excessive motion test tell me? Oh, it tells me that I got 2 surgical levels, C2, C3, C3, C4. I got 2 surgical levels. I got an upper cervical ligament injury that explains all of the traumatic brain injuries. Let's just work a neck injury up. It works up, why the person had blurred vision potentially, why they feel like they've got some cognitive impairment, the neck pain, the headaches. I've got, significant amount of treatment that I can deliver frequency-wise because of my treatment guidelines and the ICA or the Cronk treatment guidelines. I've got a permanency of a 25% or more of a impairment equal to a greater than 50% fracture. On my surgical guidelines, I'm basically the patient's qualified for spinal fusion surgery for that injury. Under athletic return to play parameter guidelines, I should restrict activity if they're in any kind of contact activity, like any kind of contact sport. And under my treatment guidelines, just in that scenario, I have more than 76 visits in a 52-week treatment duration based on my findings here. So I got plenty of time. Nobody can say that I, over-treated this thing. And future-wise, if this patient, depending on what their history was like, how old they are, how good a shape they are, how good a shape was their body deconditioned when they got into this accident, how many, are they a pack of cigarettes, 2 pack of cigarette smoker? Do they drink regularly? Do they eat really poor diet? Are they eating McDonald's 5 times a week? There's a lot of factors that go into this, right? But these are the factors of the person. You take the person as they are. So, being in a deposition, all I'm doing is explaining these things. And I'm getting paid very, very well to do it. Very well to do it. But here's what I'm going to tell you. In deposition is an opportunity. It's a significant opportunity because when you're in deposition, so there's a thing in deposition. 1, simple communication communicates. And that's a key that I need you to understand. Simple communication communicates. Complex communication does not communicate. So in a deposition, it's imperative that your communication communicates. Therefore, it must be simple. And so if you're into complex explanations, nobody understands what the hell you're talking about. So nobody understands. It's all blank during that period. You could be saying the greatest, most explanatory information, and nobody in the room understands it. So it doesn't communicate. So great depositions are ones that everybody in the room, the judge, the jury, the defense attorney, the plaintiff attorney, everyone understands it. When I talked about guidelines, anybody can read it. And look, this is the impairment level. Oh, this is what it correlates to the bone. Oh, look at the surgical guy. Hey, see this? Yeah, this much back and forth motion qualifies the person for surgery. That's what the pain management said also. That's what the surgeon said also. We have consistent medical records because you're working with a group of providers that understand what you do and can back you up. If you don't have that, you should develop that. So it's just that easy. And when it becomes that easy, you have an opportunity because now all of your remember I told you need to be a clinical rationale expert. That's where you're at. You're not your advocate for anything other than that. In deposition is where that all shows up. It's where you basically get to shine and just display your information. And it's all information that everybody else has already agreed upon. So it's all consensus. It's already agreed upon. It's very difficult to argue. That's called staying on offense. You defense junkies want to defend everything. You want to go into, why your care was necessary. And you want to start to go into defense and defending yourself. When you're in that position, you're not doing that well in deposition. So that's what we do. That's what I train doctors to do in our program called the Smart Injury Doctors Program. If you're interested in our programs, go out to our website. What we do is we help get you clinically right and legally tight in far less time than you ever thought possible. If you have questions, you want to schedule a mini session with me while I'm still doing them, 727-306-2267. That's a 30-minute free session. That's how sometimes people get involved with us, or they go out to our website. We have so many different ways to get involved with us. Right now, we have over 600 doctors that are in some form of have received some form of training from us. And by the end of 2026, we're looking to take that to 1,500 to 2,000 doctors. That's how important this area is to me on standardizing spinal injury workups. So, doctors, as always, I appreciate your time and attention. Just short riff on a topic. And I hope you gain something from it. I look forward to delivering more content on the next podcast.
You've been listening to the Smart Injury Doctors Podcast, the #1 audio production show for professionals in the U.S. injury market that want to deliver better injury services to the patients, clients, or insureds they serve. If you like what you heard today, please leave us a review and don't forget to join us on our next program.